Thank you all for joining me today. This is Advanced Neuroendocrine Foundations. If you've ever had the experience of using therapy like amino acid supplementation to address neurotransmitter imbalance and your patient just isn't improving as much as you would like them to, this presentation is going to be of great support. So today I want to address the idea that there is much more to treating these cases than just boosting neurotransmitter levels. We've got all sorts of factors that are going to sabotage neurotransmitter function. And so oftentimes we have to just take things a few steps further than just looking at the neurotransmitter levels and modulating that accordingly. Now, these are the symptoms that might drive you to choose neurotransmitter testing with the patient. Most of these symptoms can be categorized as mental health symptoms, either directly or indirectly. So things indirectly like IBS or chronic pain. LabRx by Doctors Data offers two profiles. It's the NeuroBasic, which is going to give you what I consider the main backbone to these neurotransmitters, things like serotonin, dopamine, and glutamate. And then you have the comprehensive neurotransmitter profile, which provides a deeper dive into this system, providing not just that main backbone, but also some additional neurotransmitters and many of the metabolites. Now, the imbalances identified with testing can be addressed with targeted therapies, things like amino acids, and they are precursors to these neurotransmitters, but also things like nervine or adaptogenic herbs, methylation, and basic nutrient support, things like the B vitamins. This is a multi-page handout called the Supplementation Considerations Guide. Can be a great starting point to learn how to go about treating highs or lows of all possible test markers. And again, very helpful starting point. However, neurotransmitter testing and that supplementation considerations document is not necessarily a magic bullet. Each of our patients needs a comprehensive and multi-dimensional approach, right? They look quite linear on that neurotransmitter testing report, but they are a three-dimensional being. When symptoms persist after you're directly addressing these imbalances, it just it's hinting to you that we've got to dive deeper. So there are some other areas that are important to think about when you're addressing this. And if you think about the definition of disease, I think this is a beautiful definition. It's the disruption in the flow of information among cells and between organs. So it makes perfect sense that we have to contemplate the function of so many other organ systems at the same time and right alongside the neurotransmitters. So let's start our journey today with a case study. This is Molly. She's 53 years old, postmenopausal, mother of 3 children. She's got a ton going on, so she's not exercising. She's eating a standard American diet, has a history of mood concerns, and she knows that she will soon have an empty nest. And so she really wants to use this time to focus on herself, knowing that this transition is coming up. Her symptoms here led me to determine that we could start with hormone and neurotransmitter testing. And I felt like that would usually get us, gets us a good chunk of the way to health. So she had weight gain, hot flashes, insomnia, fatigue, poor memory, depression, anxiety, low libido, and digestive complaints. Probably a list that looks very familiar to you. Many patients, especially postmenopausally, will come in menopause and postmenopause will come in with these types of complaints. She's also dealing with ankylosing spondylitis, which is causing a lot of back pain. And here you can see Molly's hormone report. Her estradiol is at the top end of normal, likely pushed to the edge due to aromatization from her elevated testosterone. Elevated androgens in women, so DHEA and testosterone, signify usually insulin resistance, especially if both are elevated at the same time. Progesterone, those expected to be quite low in a postmenopausal female. Here, hers is even lower than what we might expect. Cortisol levels really skimming the bottom of that diurnal curve. You can see, I think it's easy to see that by looking at the graph first and foremost. You can see just kind of skimming the bottom there. And this is her NeuroBasic report. We're going to visit Molly, revisit her at the end of this lecture. And at this point, I'd like you to maybe think about what you would do treatment-wise for her, given what I showed you on her hormone report and this NeuroBasic report. Maybe just jot down a few ideas, and then I'll show you what I did at the end and what I learned based on that, and we can learn together. So if we honor the idea that the body has this inherent drive to heal itself, we can help the body to do this by removing what are considered the obstacles to cure. And there are many. One big one is blood glucose imbalance. So when blood glucose levels drop too low and the person is fairly healthy, the adrenal glands are going to release cortisol. That triggers the breakdown of glycogen, which is stored in the liver and the muscles, to get glucose levels in the bloodstream back up. However, you can see if a person's cortisol levels are low, which is often the case in HPA axis dysfunction, especially in adults, that release of glycogen cannot significantly be triggered enough to raise blood sugar. And instead, the adrenals are going to release epinephrine and norepinephrine as a backup to try to get that to happen. So these are those fight or flight substances that cause a person maybe to wake in the middle of the night, say 3 a.m., filled with anxiety for seemingly no reason. Also, sometimes patients with this type of issue will present with nausea upon waking. Now, we can do an entire lecture on stress, maybe an entire weekend, but it is important in this context too. Chronic stress can be a very significant obstacle to cure, probably one of the most common ones that we're all facing today. It literally shrinks the brain and degrades the blood-brain barrier. So stress can be physiologic, mental, emotional, or environmental. And you can see some examples listed here, but it's almost an infinite list. Chronic stress has been shown to damage the hippocampus, and that in part helps to drive the sleep-wake cycle. So insomnia, as we get more in this chronic stress situation, is a very real thing. And remember that excess adipose tissue, especially that abdominal adiposity, is quite inflammatory and is therefore a stressor in and of itself. Stress also causes elevations in the inflammatory cytokine IL-6, which further enhances the sympathetic stress response. So for instance, there have been some studies showing that getting in a heated argument, say with your spouse, can raise these IL-6 levels, and that elevation can last for several days. So the midbrain gets flooded with IL-6 during these long periods of extreme stress, things like war, pandemics, and makes the brain and the body extremely sensitive to any stimuli, even something benign. So a loud sound or a flash of light, that can actually trigger an inappropriately huge stress response. So your patients may describe this to you in many different ways, but in other words, it's just that chronic stress and inflammation make the brain highly efficient at responding to stress, even tiny, minute stressors. So when you see symptoms of neuroendocrine imbalance, stress is likely a contributor. It may be appropriate to look at both the HPA axis, but beyond that too. So in addition to adaptogens and glandulars and nutrients, you want to think about treating brain inflammation. And I put together a nice list there of some of the top ones that I consider, but dietary flavonoids, EGCG, which is found in green tea, resveratrol, curcumin, and then some fun things like lion's mane mushroom and bacopa. Bacopa is a wonderful one. Omegas or B12, and then things like meditation and vagal nerve stimulation. So you can do all of that in addition to looking at the neurotransmitter report, adjusting as necessary and adjusting for blood sugar imbalances. Those would be a really comprehensive way to do that. And then one of the most vital nutrients for the brain, don't forget, is actually oxygen. And in order to get oxygen, our patients need healthy blood vessels and proper circulation. Now, stress causes shallow breathing that keeps the body in a fight or flight state, and that shunts the blood to the limbs, the heart, and the lungs. Now, think about other factors too that could contribute to this. So lack of oxygen in the brain, anemia would be a very common one, iron deficiency anemia, smoking or low blood pressure, but really anything that is going to impair blood vessels. So also think about diabetes, potentially hypothyroidism. And then consider these factors when and maybe before you're choosing therapies, because if your patient has a huge obstacle to cure here, these therapies may not work as potently as they potentially could if there's poor circulation and these items aren't getting to the brain in the first place. Digestion is another big consideration, not to be overlooked. The health of the GI system allows for nutrient absorption, and this has a profound effect on the neurotransmitters. So I'm often asked if neurotransmitter imbalance can be addressed with diet alone, and my answer is theoretically, yes, but we all know that when working in clinical practice, the lives of our patients and thus their physiology and biochemistry is quite complex. They don't live in a vacuum where we can perfect their stress, their diet, their exercise regimens, and their sleep, right? That would be nice if we could, but we can't. Most Americans are eating enough protein-rich foods to supply what should be the appropriate amount of amino acid precursor to produce all of these neurotransmitters. Yet we still very commonly see imbalances, a lot of times low levels. So the issue is not a lack of amino acids necessarily, but likely how are they being absorbed, and then how are they being utilized thereafter? Are there any obstacles to cure there? A big one is this: someone eating a food that's sensitive, that they're sensitive to, causes inflammation. They continue to consume it, it's going to prevent optimal functioning of the gastrointestinal tract. So these are the most common food sensitivities here: milk, eggs, peanuts, soy, shellfish, corn, and gluten. And I want to back us up to over 5,000 years ago. Ayurvedic medicine describes what they termed the Agni. This is kind of like saying the digestive fire. So that strength of the digestive system will weaken with stress, with things like overeating or eating on the run or poor nutrition. And so I would assume most of our patients are dealing with at least some part of this. When that happens, there's diminished hydrochloric acid and pancreatic enzymes that inhibits food breakdown and increases what Ayurveda refers to as ama, or this toxic buildup. So common food sensitivities, things like wheat and dairy, usually these proteins and these food particles are some of the most complex for our digestive system to break down. Thus, they are some of the first foods to become problematic. Now, there's other things involved too, environmental toxins and pesticides, but this is my common reasoning for why these food sensitivities are most prevalent in our patient population. And I think really clinically pertinent to this is not to just remove those foods entirely from all of your patients, but to think about, okay, we need to remove them potentially for a time, but now we need to go in and strengthen that digestive system so that our patients maybe one day are able to eat a wider variety of foods and not have so much trouble. Now, this study looked essentially at Americans in 1950 versus 2000 and saw that the prevalence of celiac disease increased dramatically in the past 50 years. So in 1950, 1 in 700 people had celiac, and then now it's 1 in 100. Over the years, gluten has been hybridized and deaminated. So these are processes that have rendered it very inflammatory to humans. Not to be confused with genetic modification, but hybridization creates a new protein by combining different strains of the wheat. And over time, that can alter the protein sequence by as much as 5%. So it's a quite different molecule from the original source. And then the deamination makes wheat easier to use. It's more water soluble. And that's actually been shown to create severe immune responses in people. And there was a trial looking at subjects who did not react to the native wheat flour, but reacted very severely to this deaminated wheat. So these processes have been linked to a sharp increase in sensitivity in celiac disease, but also inflammation, degeneration, and even autoimmunity of the brain and the nervous system. In fact, gluten sensitivity seems to destroy the brain and nervous system, that tissue, more than any other tissue in the whole body, including the GI tract. So very important to think about this too. Doctors Data offers both a serum and a blood spot option for looking at celiac disease and gluten sensitivity. So you can see examples of that here in this slide. Now, celiac disease can cause an array of nutrient deficiencies because the intestine is affected. Studies show that even after a year of a completely gluten-free diet, malabsorption can still be an issue. And then we've also got the problem of incidental exposure that happens even when patients are being very, very careful. We also have processed gluten-free foods, hopefully our patients aren't relying so much on those, but reality is they're probably getting in some. Those are highly, they're not fortified like some of the other processed foods are, so that can result further in nutrient deficiencies. You can see how at multiple levels, even if your patient is celiac and totally gluten-free, there's still going to be some problems in nutrient absorption and potentially some deficiencies. So folate deficiency, very common, associated with depression, a poor response to antidepressants, and then a higher relapse rate for depression. And folate supplementation, on the other hand, has been shown to enhance the effect of antidepressants. Now, it's pretty common for patients to be deficient in folate. It's not just those with celiac. You want to look out for these other risk factors, so potentially medications that can contribute. So oral contraceptive pills would be a common one. Metformin is another common one, and even fluoxetine or Prozac. There is a website that I wanted to mention to you all that I find very helpful. It's called mytavin.com, mytavin.com. And it's a wonderful resource database where you can plug in a medication that a patient is on, and it will tell you the evidence-based research that's been linked to nutrient deficiencies for that medication. So you can be proactive here and get ahead of this and treat those deficiencies. Diabetes and hypothyroidism, alcohol intake, simply aging can lower folate levels, MTHF polymorphisms, and probably obvious to you, but also obesity. So this was a study looking at 28 weeks of fluoxetine treatment at 20 milligrams per day. The relapse rate for patients with low folate levels was 42.9%, and compared that to normal folate levels, that relapse rate was only 3.2%. So pretty drastic difference there. Folate deficiency, whether it's diet-related, genetic, or drug-induced, can contribute to a whole variety of central nervous system disorders. I found this visual really helpful, so I just wanted you to have it. No, we won't spend a ton of time on it. Iron, also a cofactor in the conversion from tryptophan to 5-HTP. 5-HTP then goes to serotonin. So iron is necessary for serotonin. Also, it's a cofactor in the transition from tyrosine to L-DOPA, which then converts to dopamine. So we need it for serotonin. We also need it for dopamine. It's commonly deficient in those women who are still cycling, especially if they have heavy menses, and then those with malabsorption issues, including gluten intolerance. Hypothyroidism is also impairing the abilities of a body to absorb iron. Also those with low hydrochloric acid, so weakened agni or digestive strength, digestive fire. These serum zinc levels have been inversely correlated to depression. Women who took a multivitamin and zinc showed improvement and reduction in anger, hostility, and depression. The HDRS word that you see there stands for Hamilton Depression Rating Score, and the Beck Depression Inventory is that BDI. And here we have a meta-analysis, 17 studies supporting the idea that depression is associated with low zinc levels. So remember, zinc isn't just for immunity, or maybe you think about it for building testosterone, which is also great, very common, but we should be considering it for mental health as well. And doctors have understood the benefits of magnesium for a long time now. We go all the way back to 1921, where we see the first documented study on this. Repletion of magnesium improved mood, showed healthier eating patterns, and improved their response to stress and sleep. This was a study looking at the relationship between magnesium and depression in almost 9,000 adults over a span of 4 years. They found a significant association between low magnesium intake and depression, and that was especially true for the younger adults. This is a very interesting study looking at nutrition and behavior. It's a double-blind placebo-controlled trial of nutritional supplements on about 200 young adult prisoners, and they compared the disciplinary offenses before and during supplementation for approximately 4 months. Those who were taking the supplements for at least 2 weeks had a 35% reduction in offenses on average, and they were just simply supplementing a standard multivitamin, mineral, and omegas. So imagine if we could get everyone on that. Vitamin D controls transcription for over 1,000 genes involving the nervous system. Vitamin D is a cofactor in the production of serotonin and dopamine, so similar to iron. And this is one theory as to the etiology of seasonal affective disorders. Vitamin D is lowest in the winter months and can result and be correlated to depression. Lots of studies come from the military. The VA has a large database of patients, and depression and suicide are unfortunately a very significant problem in active duty service members. This was a case-controlled study. More than 30% of those looked at had vitamin D levels below 20 nanograms per milliliter. Now, the gut microbiome. Enough cannot be said about this. Microorganisms here outnumber human cells 10 to 1 and make up about 1 to 3% of the body's mass. So for reference, in a 200-pound adult, that would be 2 to 6 pounds of bacteria. And then more than 10,000 microbial species occupy this system. And it's really those early years of the environment and the diet that seem to create this microbiome. So the first 3 years of life, very crucial to establish the diversity of that microbiome and fine-tune the bacterial host symbiosis, which is what we're hoping for, symbiosis there, working together. That then influences the development of the immune system and the neurologic system. This is the GI 360 microbiome profile. It's a gut microbiota DNA analysis tool that measures more than 45 analytes across different phyla using PCR, and that compares to a normobiotic reference population. So the web chart that you see at the upper right illustrates the degree to which the person's microbiome deviates from what's considered normobiosis. And then the dysbiosis index score, that DI score, goes from 1 to 5. A DI score above 2 is considered to be dysbiotic. And then the higher the DI score above 2, the more the sample deviates from the normobiotic profile. Studies show this bidirectional relationship between the gut microbiome and brain function so that we can potentially modulate the gut microbiome to be therapeutic for all different types of central nervous system disorders. This is kind of the cutting edge of what we're trying to understand right now. And though it's early on, I think the research is very exciting. So lots of studies first we'll talk about in rodents and other animals. Some of these are using germ-free mice, some are using pathogen-free mice, and then some have included various stressors. All in all, we can see that consistently treating animals with, say, a wide spectrum antibiotic has been shown to affect behavior, sometimes for better, sometimes for worse, and that pathogenic bacteria induce anxiety-like behaviors in these animals. If we do fecal transplants, that can alter behavior and even body mass index to match the donor. Probiotics have been shown to decrease visceral pain, improve immunity, and improve mood when there's a stress-related psychiatric condition involved. Taking probiotics can ease anxiety and depression-like behaviors. This has been shown in both animal and human models. And this study was outlining 3 possible mechanisms here that would explain what's going on. So first of all, potentially competitive exclusion of the pathogenic microbes, right? Build up what are considered beneficial, and that crowds out the bad ones. And then decreasing inflammatory cytokines, likely happening at the very same time. Also, communication with the central nervous system through the vagus nerve. Vagus nerve is very important for that parasympathetic nervous system tone, so thus decreasing anxiety. Leaky gut, you've heard this term. It's basically lack of integrity of those tight junctions that should be present in the intestinal epithelium. So when these tight junctions become looser and have these little holes in them, that can cause inflammation and really upregulate and activate the immune system. Circulating zonulin is a very clinically useful marker for this intestinal permeability. And so with DDI, you can test that in either the serum or the stool. So probably not surprising to hear that chronic systemic inflammation, we can probably all agree, is the enemy to health. It releases cytokines, which then send messages across the blood-brain barrier to activate inflammation in the brain. And that, if chronic, can alter the function and even destroy that brain tissue. So say a person is gluten intolerant, not able to eliminate that food, they can experience brain fog and mood concerns, even if they're not experiencing GI issues. And then the other hand, inflammation primarily starting in the brain can also activate the body's immune system and trigger systemic inflammation that can manifest, say, as joint pain, gut pain, skin disorders, on and on. An example of this would be a person who sustains maybe a head injury and suddenly then develops an autoimmune disease shortly thereafter. Now, the blood-brain barrier is designed to allow only nano-sized particles in or out as needed and to keep basically all unhealthy things out. It's extremely vulnerable to inflammation. So if you think about leaky gut, we also have what we can maybe refer to as leaky brain. Now, once the cytokine signals reach the brain, they have the capacity to influence the synthesis, the release, and the reuptake of neurotransmitters like serotonin, dopamine, and norepinephrine. So imagine, even if we have amino acids that are there and readily available in the diet to produce these neurotransmitters, if we have inflammation and cytokines reaching the brain, that's going to sabotage the ability of these neurotransmitters to function. So more and more research supports the idea that depression, while likely a disease, maybe you could say unto itself, may actually be a symptom of inflammation. I'm sure that you've heard this before. The title of this paper might be the very sentence that is rolling around in your head right now. So if depression is an inflammatory disease, where is the inflammation coming from? Well, this is our challenge as clinicians. This paper outlines some of the areas that should not be overlooked when we're trying to answer this question. Certainly, things like psychosocial stressors, poor diet can create inflammation, physical inactivity, obesity, smoking, altered gut permeability, dental cavities, poor sleep, vitamin D deficiency. These are all nutrient deficiencies. These are considered obstacles to cure. It might look familiar from what we've been talking about, and many times are the cause of the inflammation. Usually it's not just one cause either, which makes things a little bit more tricky for us. Omegas are important for the structural integrity of the brain. So some studies have looked at this. 10 weeks for cellular membranes to recover after chronic omega deficiency. So don't let your patients quit omegas after a month or two thinking, nothing's really helping, and telling you that they're not working. So when it comes to brain health, I usually ask patients to please be willing to stick with this for at least 6 months before we move on to something else. Patients oftentimes just need that little bit of timeline and put that realistically in front of them. They're oftentimes taught that things are going to, fix with a pharmaceutical overnight or within a few days. So they really just need to be taught this. And I find usually as long as we set up that expectation, they do just fine. They say, okay, yeah, I can definitely do that, right? But if we don't tell them that, it's going to feel like 10 weeks is just way too long and things are not working. This is a meta-analysis of 13 randomized placebo-controlled trials. They were looking at omega-3s and said they were as effective and comparable to antidepressants in the treatment of depression. Sadly, low omega-3 levels, or omega-3 and 6, the healthy 6, have been linked to increased suicides. And it's common to get the omegas and other nutrients from food. And in fact, as functional medicine providers, we're often quoting Hippocrates here, let food be thy medicine. The problem is our patients are looking at us going, well, but what food? Should I be on the paleo diet, keto diet, Mediterranean? Some foods in particular have been studied specifically to depression. So high intake of fruits and vegetables, soy products, mushrooms, seaweed, and fish associated with a decreased risk of depression, but also suicide. And then the Mediterranean diet has been most studied in relation to cognitive outcomes, even dementia and Alzheimer's. So avoiding processed foods probably is a no-brainer to you. Your patients probably know this, whether or not they're implementing it or not is another factor. But really, patients are still always wondering, tell me exactly what to eat. I want to know what's the perfect diet, right? And the fact is, I don't know that there's one perfect diet out there. Indigenous diets can provide us clues, but depending on where you are and where you're looking at, you can see that they vary quite a bit. a ton, especially the macronutrients, where Eskimos are having 80% fat, very low carb, and other areas have very high carbohydrate and low fat intake. But what I think we can take away from this is that all in all of these diets are avoiding simple sugars and processed carbohydrates, and they're providing good fats. They're not afraid of the fats. They're whole foods. They're not eating out of packages. So sometimes we don't have to get much more fancy than that. So let's move along now to these neuroendocrine interactions. First of all, the thyroid and neurotransmitters. So there's an association between thyroid hormones and mood. You probably think, well, obviously, because you see this in clinical practice so commonly. Clinical depression occurs in over 40% of those with hypothyroidism. And then subclinical hypothyroidism is a major factor for major depressive disorder. We also see antithyroid antibodies present between 9 and 20% of those who have suffered from major depressive disorder. So very strong links there. In regards to dopamine, thyroid hormones have been shown to regulate levels of dopamine receptors and the activity of tyrosine hydroxylase. So think low thyroid, probably low dopamine. With serotonin, we see diminished serotonin activity in hypothyroid patients, and that's reversed when thyroid replacement is utilized. Glutamate, in regards to this, T3, the active form of thyroid hormone, protects against glutamate toxicity. So that is another factor. Hypothyroidism slows glutamate decarboxylase, or GAD. That activity of that enzyme, it converts glutamate to GABA. And then T3 increases that activity of glutamate decarboxylase. So helping to support that. Low thyroid function associated with delayed myelination in several of the brain regions. And then thyroid hormones regulate neuron proliferation, synapse formation, and differentiation. Bottom line here, the thyroid is a big deal in brain function. It is a massive obstacle to cure if it's not functioning appropriately, or if you are, say, having a patient with thyroid hormone replacement that's not at the right dose. You really need to clue in on that and not expect neurotransmitters and other things to improve until that is improved as well. This shows that simply the presence of having thyroid antibodies, even without overt thyroid dysfunction, has been associated with a higher risk of postpartum depression. Patients with thyroid insufficiency are especially sensitive to develop depression. And as a treatment pearl, many clinicians are often providing T3 treatment and seeing that of benefit in depression, even in those with euthyroid or a normal functioning thyroid. So something to consider. T3 has been also shown to make antidepressant therapies work better, much like we saw with folate. One theory behind this is that thyroid hormone directly activates several enzymes that are involved in that creation, and then increases the sensitivity of the receptors as well. So that may be the reason why. So moving right along, we're going to shift gears here now and move away from gastrointestinal health and thyroid. We're going to look specifically at sex hormones and neurotransmitter interactions. The male brain is anatomically different than the female brain. I don't know if that sounds obvious to you or not, but I do think this is a very interesting research subject matter. So men seem to have a larger hypothalamus than women, and men have more white matter. And that white matter is essential for relaying information and for cognitive function, whereas the female brain has much more gray matter that governs sensory perception. So seeing, hearing, emotional experience, memory, speech, and also muscle control. The frontal lobe, this is the emotional control center and the neurologic seat of our personality, also differs between the sexes. The male frontal lobe has more receptor sites for testosterone, and female frontal lobe more receptor sites for estrogen. That frontal lobe generates motivation and drive. And it's common to see women with low estrogen and men with low testosterone really suffering with depression and poor motivation. So that might make sense given what we know about that frontal lobe now. This has been a small very small but very interesting research on how sex changes affect the shape of the brain. So patients undergoing a sex change are given obviously large amounts of hormones, and researchers have looked at the brain MRIs before, during, and after these hormone treatments. There was a study, again, very small, 8 subjects who were undergoing male to female transition, 6 subjects who were undergoing female to male transition, and this is what the researchers found. The males who were transitioning to females began developing more gray matter, right? That's what we saw a couple slides ago. Those that were receiving high amounts of male hormones developed a larger hypothalamus and had more of the white matter. So these are potent hormone doses, maybe not what you're using on an average day in clinical practice, but in just 4 months, the subject's brains actually changed to take on the shape and structure of the opposite sex. Now, we see many men who have either too much estrogen or too little testosterone, or both, and then women are usually deficient in progesterone and either have too much or too little estrogen, and then sometimes often too much testosterone. So think about these hormonal shifts could potentially be changing the shape of the brain. And then more connections here between hormones and neurotransmitters. There are anxiolytic effects of allopregnanolone, and that's mediated by the GABA-A receptor. So when you give oral progesterone, it is metabolized upon digestion, basically. It turns into allopregnanolone. And this is why we often will give this before bed. Not only are we calming the nervous system in general, but we're also helping the body to fall into a sleep rhythm by stimulating those GABA-A receptors. Here we see serotonin levels drop in menopause, whether that's natural menopause or surgical menopause. And then when estrogen therapy was utilized, serotonin levels went back up to the levels that we see in menstruating women. Very interesting. Serotonin also low in amenorrheic women. That would make sense. They're not menstruating. Estrogen levels are lower, and therefore so are serotonin levels. Perimenopausal and menopausal women who have less estradiol levels usually are complaining of mood and cognitive concerns, and then giving estradiol looks to reverse those symptoms. This primary mechanism might be MAO inhibition. I'm going to show you here. Serotonin breaks down to 5-HIAA through the MAO enzyme. So if we have inhibition of this, we have less breakdown and more serotonin available. And then estradiol also increases the activity of the tryptophan hydroxylase enzyme. So you can see that here, going from tryptophan to 5-HTP, tryptophan hydroxylase, right? Requires these cofactors, but estradiol increases the activity of that enzyme, so helps move to serotonin. In men, testosterone is thought to be the most impactful hormone, whereas in women, we think it's estradiol. These levels commonly decrease with age, and that can result in changes in mood and mental state. This was a rodent study. They gave testosterone, and it increased serotonin receptor sites, resulting in greater serotonin activity, and therefore they saw an improvement in cognition, mood, and mental state. Interestingly, estrogen also increases these serotonin binding sites in males, but this doesn't happen when DHT is given. So DHT is a potent androgen. It actually cannot convert to estrogen like testosterone does. So it suggests that the action of testosterone depends on its conversion to estrogen by aromatase. So might make you a little cautious about giving either a pharmaceutical or a natural aromatase inhibitor with maybe that person has low testosterone, but they also have a lot of mood issues. You might just want to be cautious about that because this could be also inhibiting serotonin. Strong connection between dopamine and memory. Even minor fluctuations in dopamine can profoundly alter memory. Estradiol has been shown to enhance dopamine activity and thus affect memory and mood. Dopamine and testosterone. Researchers found that the administration of dopamine, a dopamine agonist, so building up dopamine in rat brains, increased the amount of gonadotropin releasing hormone that was produced from the hypothalamus. That hormone signals the pituitary to secrete luteinizing hormone, which then in turn signals the gonads to produce testosterone. So there's another connection right there. Not only that, but dopamine and testosterone seem to have this bidirectional relationship. The brain's medial preoptic area, we refer to as MPA, that releases gonadotropin-releasing hormone and seems to control sexual function in males. In a rat study, they did micro injections of a dopamine agonist, so boosting dopamine in that area of the brain, and that resulted in increase of sexual activity. Another study kind of supports this. They looked at castrated male rats who had no dopamine released in that MPA area of the brain and no sexual interest. After they gave these rats testosterone injections, these rats got their libido back and at the same time increased their dopamine levels that was released from that MPA area. Dopamine and serotonin can acutely stimulate testosterone production, as we've seen. But watch out for stress because epinephrine will inhibit testosterone production. So under significant stressors, the body and brain are going to deprioritize sex. So make sure you're watching out for this. This is a huge issue in low libido. Now, we're all familiar with the term roid rage. I think you've probably heard of that. The idea that men who are taking too much testosterone can present with a lot of anger and aggression. That aggression seems to be attenuated by serotonin, so softened by serotonin. In animals that had high testosterone and low serotonin levels, they had aggressive behavior that increased. However, if the animals had adequate levels of serotonin and they were given testosterone, even to high levels, the aggression and the impulse behaviors decreased. So, bring this to real life. If you're using testosterone therapy and aggression seems to be a bothersome side effect for your patient, do consider testing, making sure serotonin levels are adequate. This was a study of 4,000 depressed men who had low T. They were given testosterone and their symptoms of depression improved. So none of these studies were actually looking at neurotransmitters involved with this improvement, but I did want to mention it because the benefits of testosterone therapy for depression could be quite significant. So to summarize, healthy estradiol levels improve serotonin and dopamine in both males and females, thus improving mood and cognitive concerns. Allopregnanolone is anxiolytic due to that GABA A receptor stimulation. Dopamine enhances testosterone secretion in males and vice versa. And then serotonin attenuates aggression that we see sometimes with testosterone therapy. Okay, moving right along here, stress, cortisol, and neurotransmitters. So in response to a stressor, our body immediately releases epinephrine and norepinephrine, and then moments later, cortisol is released. Altogether, this allows us to either freeze, fight, or flee. But not commonly known, serotonin also plays an essential role in this entire cascade. So in the presence of stress, serotonin and actually acetylcholine tells the hypothalamus to release what's called corticotropin-releasing hormone. Now that corticotropin-releasing hormone stimulates ACTH, and that directly stimulates cortisol secretion. But if serotonin is inadequate, these signals may become compromised. Now, chronic stress has been shown to eventually deplete the catecholamines, so dopamine, epinephrine, and norepinephrine. And then depletion of those catecholamines has actually been closely related to stress-induced performance decline. So think of your patients, if some of them are in school or have testing measures that they have to go through or have to do public speaking or anything like that, this can be involved there. So you want to make sure their catecholamines are reasonable. Now, you can think about stress in 3 stages. The symptoms that patients present with, no matter where they are in these phases, unfortunately can look exactly the same. You know, your patients are tired, they're moody, they have brain fog, they have poor sleep, and they all move through various stages of stress at various rates. So that makes it really hard to understand exactly where they're at in these phases without testing. But if you test patients at an early age or stage of this process, you're typically going to find, decent energy levels, although they're probably feeling stressed. The body is really good at responding to stress for a certain period of time. Patients may not be feeling great, but they're generally able to get through their day and get everything done. This is a case example of what you might see here with an early stress response. So both norepinephrine and epinephrine can respond, although I found epinephrine to be most tied to that stress response. And then elevated cortisol levels here, classically, you would see elevations all throughout the day. So the sympathetic nervous system isn't designed to stay in high stress mode without a break for the course of months or years. Now, the adrenal gland, it's important to know, doesn't actually fatigue. It's commonly called adrenal fatigue, but it's kind of an incorrect term. It should be HPA axis dysfunction. The sympathetic response to the HPA axis adapts to this constant onslaught of stressful stimuli, and it downregulates. So at this point in the phase, the NTs might be high or low. Some might still be holding on for dear life, but generally the cortisol curve looks suboptimal, especially that first morning curve, first morning level. If you compare that to the last one, that one drops significantly. These patients might start to complain of fatigue, impaired cognition. They might have some energy some days, but then maybe feel burned out other days. They may be having and dealing with some depression or anxiety. And then in a late stage, phase 3, these systems are depleted and exhausted. People usually do not feel good here. And because cortisol, norepinephrine, and epinephrine are all key players in the stress response, and patients are usually dealing with at least some degree of stress today, I think it's really helpful to test these things together if you're able to. A lot of times we go straight for the cortisol testing and kind of forget that the neurotransmitter levels can be of help as well. So one last section here, neurotransmitters and couch potato syndrome, metabolic syndrome. Here we go. Metabolic syndrome is a state of sympathetic nerve hyperactivity. This study, interestingly, tells us that insulin and norepinephrine cooperate independently to each other, but both at the same time in the development of metabolic syndrome. So both are increased in metabolic syndrome. You see the diagnostic criteria listed right there on the right. Insulin seems to be the determinant for the negative metabolic aspects, whereas the catecholamines seem to be important for the development of things like hypertension and impaired glucose metabolism. So both of those things involved. Now, we get to revisit Molly, who's our patient from the very beginning of this presentation. Remember, she had what we can consider estrogen dominance. Her estrogen was nearing the top of that range, and she had quite low progesterone. Her androgens were elevated, suggesting dysglycemia and insulin resistance. And then she had phase 3 HPA axis dysfunction, so really kind of the bottom of that curve. So her imbalances are in line with her reported symptoms. We see low range serotonin and low dopamine. That's associated with mood concerns, decreased cognitive abilities and cravings. And then her upper range norepi and epi, we see usually anxiety, irritability, insomnia, those types of things. She definitely has that. And then she's got upper range glutamate, definitely maybe contributory to her anxiety, poor concentration, nighttime waking. Low GABA, remember that's very inhibitory. So if you don't have enough of that, you may be dealing with anxiety and the inability to sleep well. Low histamine, that can affect learning, memory, and mood. And low PEA, that's associated with cognitive concerns. So she's got a whole array of things going on here. Her upper range norepi, remember, associated with metabolic syndrome. And this actually plays out in her blood work. Her trigs are a little high. She's got high LDL, HDL is a little low. Her A1C suggests prediabetes. Her fasting glucose is not optimal. Vitamin D is suboptimal. And because her blood pressure is a smidge high and her lipids, blood glucose abnormal, we're basically dealing with a case of metabolic syndrome here. So these are Molly's obstacles to cure. They should look pretty familiar by now. We've got inflammation, certainly, from ankylosing spondylitis, but also obesity. She's got diarrhea, so likely we've got inflammation in the gut, potentially some food sensitivities going on, and maybe some dysbiosis. We certainly can see some blood sugar imbalances. We see estrogen dominance. We see stress involved. Vitamin D is insufficient. And then I didn't note this here on the slide, but the pain from her ankylosing spondylitis also is a significant stressor for her. So lump that into the stress category. So knowing all of this and how it can affect the neurotransmitter levels, You wouldn't be surprised now at this point if you gave Molly some 5-HTP and maybe some tyrosine, hoping to boost her serotonin and dopamine, but it didn't quite turn her life around, right? It's easy to look at these linear tests and just plug in some supplements and hope for the best. The problem is we now know with all these obstacles to cure, we really have to take that testing, but dive into it further, especially looking for inflammation. So take a look at your treatment ideas and what you had in mind for Molly, and maybe compare them here to what I chose for her. Again, there's no wrong answers. There's so many different ways to heal, but this is what I chose to do with her. We're going to address estrogen dominance with progesterone supplementation. We're going to address the dysglycemia and the insulin resistance by decreasing simple carbohydrate intake, giving her nutrients that help with blood sugar regulation. And that's going to hopefully lower her testosterone and DHEA, and thus also lower the aromatization that's happening, pushing her estrogen to the upper range there. And then we're going to address her impaired stress response with adaptogens and nutrients, and actually hydrocortisone as well. I don't use that in everyone, but she was having a pretty hard time, so we went for it. I also gave her a B complex with activated forms. So the P5P, or the active form of B6 in the B complex, will help to convert glutamate into GABA. And basically the B vitamins are very intertwined with all of the neurotransmitters. And so oftentimes B complex and maybe L-theanine, you can use that as kind of like a foundational piece if you don't know where to start. Those two things are often highly a good idea. Anxiolytic herb tincture to help with the anxiety, 5-HTP, boost serotonin. I chose DL-phenylalanine rather than tyrosine because phenylalanine in one direction will boost PEA and the other direction tyrosine. So you kind of get a 2-for-1 there. And then GABA and histidine. Okay. I also took things a step further, looking for anti-inflammatory support. So vitamin D to help support mood. This has also been shown to sensitize insulin receptors. We certainly want that for her. Probiotics to address GI symptoms, fish oil for brain inflammation, melatonin for sleep support. It's also anti-inflammatory. And then we gave her an anti-inflammatory, I wouldn't call this a low carb diet, but lower carb, lower processed, especially. Daily movement, I taught her, very important, especially with ankylosing spondylitis, to attempt to avoid that vertebral fusion that can happen. And then encouraging her to do cardio as well as stretching and yoga to keep those joints mobile. So 4 months later, when I checked in with her, a lot of her symptoms had improved, but she was still dealing with some mood concerns, some sleep issues, gas and bloating, and cognitive issues. So think to yourself, maybe what steps we could go further on. Maybe what are these obstacles to cure that we haven't quite addressed yet? We've seen, this is her follow-up testing for neurotransmitters, improvement in the upper range catecholamines and the glutamate, but none of those low levels have improved. So what's going on here? Besides hormones and neurotransmitter testing, her symptoms, you may be thinking in your mind already, possibly linking to a bigger gut issue that may not be just totally satisfied with probiotic. She's potentially not absorbing the supplements that she's taking, so that 5-HTP and the tyrosine or the phenylalanine aren't boosting her levels like we would expect them to. So we're going to take this a step further and do some more testing. This web chart illustrates the degree to which Molly's microbiome profile has deviated from what is considered to be normobiosis. So remember, a DI index score above 2 indicates dysbiosis, and hers is at a 3. Some other very interesting findings on her stool test. So let's start here at the top. The fecal pH, largely dependent on fiber fermentation. That is likely low because of the dysbiosis. She has a protein forward diet, meaning she's focusing on protein first. So she may not be getting the amounts of fiber that her body is asking for. So we're definitely going to make that adjustment for her. Klebsiella is a normal finding, but considered dysbiotic at a 3 or a 4+ level. So this overgrowth can cause gas and bloating. Certainly that's what she has. Also linked, interestingly, to ankylosing spondylitis. So we're going to really clue in on that. Diarrhea and bloating, she actually had mentioned these were worse when she ate sugar. So that's consistent with the finding of 3 strains of Candida that we see here. She also has a parasite. So diet amoeba infection, super common. It affects the large intestines. And when the parasites and overgrowth like this, you might expect to see secretory IgA elevated because that's the body's first response to infection. Hers is actually on the low side, so that might indicate to us that the infection has been there for quite a long time and her SIgA has been depleted. Now, really cool, these susceptibility testing. This provides guidance for potential intervention. So in Molly's case, we're not going to choose berberine or black walnut, right? We might choose something like caprylic acid or uva ursi. And then also prescriptive agents, we're going to avoid ampicillin and choose some other antimicrobial. Candida susceptibility. We would suggest considering 1 or 2 of the top natural treatments for 4 to 6 weeks. And then maybe, or choose from 1 pharmaceutical. This is what we chose to do with Molly. We did a prescription for the parasite. This is a standard of care for this one. The side effects of all of this prescription are pretty brutal. So Molly did have quite a bit of that. She had an upset stomach, rectal itching, eye blurriness, which can be disconcerting. So really, make sure your patients are aware of this ahead of time. We implemented some treatments to improve the microbiome. For yeast and Klebsiella, grapefruit seed extract was implicated in both. So that was a great option to, hit 2 birds with 1 stone there. And then supporting the secretory IgA, we utilized some therapies there to address the low pH or increasing soluble fiber. Remember, with her protein forward diet, she may not just be getting enough fruits and vegetables. Now, this is another factor I wanted to mention here. This is something I often talk about with my patients, not just what to eat, but how to eat. And maybe that sounds offensive, but many times in our culture, I think we just don't, in our society, we aren't taught this. Eating 3 regular meals per day at regular times, lunch being the biggest, heaviest meal, that's when the digestive strength, that agni, is at its most potent. Taking food and drink at room temperature or slightly above and not cold, that vasoconstricts the entire digestive system and it inhibits digestion. Sitting down and relaxing to eat, very important. I would say probably one of the most important treatments of this entire presentation. However, interestingly, one of the hardest for patients to implement. We are so used to, and I say we because I do this myself, just, eating on the run, eating quickly, snacking, not sitting down to give yourself that time to eat a full meal. Easy 3 deep breaths before food hits the mouth can be a really nice way to get the body into that parasympathetic rest and digest state so that it can digest the food, not create a toxic buildup, not inhibit digestion right from the get-go. Adding spices to kindle and warm the digestive system, improve that agni, that digestive strength. So most spices are warming: black pepper, ginger, turmeric, cinnamon. You get the idea. There's that energetic warmth there that can help to digest food. So this was retesting 12 months after the initial neurotransmitter testing and 6 months after the last one. So finally, you can see we are getting somewhere. Some of these lower levels have finally moved up and Molly is feeling a whole heck of a lot better. 12 months follow up to the GI 360, we see good diversity. There's abundance there. We continue that, stressing the high fiber intake. So legumes, fruits, and vegetables. The dysbiosis score indicates that the gut is now normobiotic. pH and secretory IgA now within normal limits. The parasite is gone, yeast is gone, Klebsiella is now within normal limits, which is why you don't see it reported there. She's lost 39 pounds, hot flashes improved, insomnia improved, fatigue improved, alternating constipation, diarrhea improved, stools are now well formed, gas and bloating is nearly gone, and she's less uncomfortable in her back pain and her neck. She has a little bit more range of motion. So at this point, this was what we chose to do. We discontinued some of the therapies and continued most of them. You see that there on the left. Please, please, please star this slide. Go back to it again and again and again when you're first figuring out, where do I start to treat neurotransmitter imbalances? Yes, you can certainly boost with amino acid precursors and use that supplementation considerations document. However, don't forget that you don't just stop there, right? Like, you're always thinking about root cause. It's usually going back to inflammation Where is that inflammation coming from? What are the obstacles to cure that we're facing here? And how can we be creative to work around those things? So this is going to be very, very helpful for you. Remember, we ask a lot of our patients, so be gentle with them, be patient with your patients. I always suggest telling them the why behind each and every therapy that you're implementing. So many times patients are really excited in the treatment plan and they see your thought process and all the things that you want to do and help them with, but then they get home and they see that treatment plan is just this long list of supplements and they forget why they're taking all of those things. And it can feel overwhelming and confusing for them. So if they have it written down, take probiotics for this reason. That can really help to motivate and to drive longer term treatments. And then also giving them timelines on expectation. If you're working on brain health or gut health, hey, please give me 6 months, okay? Let's really commit to this for 6 months before we start to go for a plan B or do something else, okay? Remember that testing is not the magic bullet per se, but it is certainly a huge tool. It's helpful for motivation, for goal setting, for quantification, and for tracking progress and follow-up. But there are complex interactions between hormones and neurotransmitters. So it's important to remove the obstacles to cure when you're addressing these hormone and neurotransmitter imbalances. So if you ever sit there and think, okay, where do I start? Certainly, supplementation considerations handout is going to be very helpful, but also take it further and ask, what are these obstacles to cure? What is the inflammation that's likely going on? Thank you so much, everyone, for sticking with me through all of that. Thank you.